to this as well. 2 sessions, one today and one tomorrow, we are doing.
Tomorrow is only with me. Remember, I wanted your advice on the greater research systems.
Yeah.
Today is only Nihad. I'm just listening.
Great. Excellent. Good. Yeah,
All right.
Good. Yeah, well, congratulations on getting the Rising
Okay.
Star Award, which is great.
Thank you, Prof. Yes. So I have studied under you, and I know what Tata Memorial Hospital looks like. And as head of department of one of the largest pediatric oncology units in the world, you are also a very busy researcher, a teacher to all of us, and many others, even outside of your institution. You are also a great family man, and you still make time to engage young people in training, or those who are also in their early career, and both in and outside of India. These are things that you do, it just comes naturally to you, but sometimes I think that you are also intentional about the things you do in terms of engaging young people. So why is this important to you, as having all of these things on your plate, you still make time to engage young people in their career? Why is this important to you?
Thanks, Nihad. I think that's a great question, and you'll really get me speaking from my heart on this probably. So I will tell you why I think it's very important to engage young people. So pediatric cancer, as is the case in many other specialties, is a rapidly evolving field which requires a lot of people to work as a team and build a community who will take care of children with cancer. Now, as an individual, we can do nothing. Really, it has to be the whole team which needs to develop. And if we don't, looking at the enormity of work which is there, especially in the low and middle income countries, where 80% of childhood cancers presently exist, with hardly 20-25% of the health infrastructure to take care, it would only be right for us to think for the future that how do we actually bridge this gap? And to bridge this gap, we actually need multiple initiatives to be taken. And one of them is to actually develop pediatric oncologists who are committed to in this field, who go on to become leaders in the future, and who actually go on to build their own teams. It is like a chain reaction, right? So you focus on training 8-10 people, building leaders, and they will continue to focus to build their 8-10 people. And over a period of 1, 2, 3 decades, we'll actually build a large community who can give the adequate amount of time and adequate amount of effort will be put in to take care of all the children with cancer who are there in this part in these parts of the world where care and infrastructure doesn't exist. And it is just not about developing personnel. See, we cannot just teach them the science of cancer. We actually need to teach them how to navigate cancer with limited resources. And that, I think, is what is really the crux of this. That yes, there is science, there is this, there are protocols, there are great regimens which give excellent outcomes in many parts of the world, especially in the high-income countries. But are they actually deliverable in the low and middle income countries? Can we actually implement this? We need to adapt them and see what is achievable in a pragmatic way and move the bar slowly, step by step. We shouldn't train personnel who can only cater to a small, only to certain situations. We need to create people who are actually versatile enough to adapt and need to take a call. So just to give you an example, there is, let's take a simple thing. So there is leukemia, acute lymphoblastic leukemia. So in acute lymphoblastic leukemia, you have flow cytometry, you have cytogenetics, you have now next generation sequencing, and all of those which contribute to appropriate risk stratification of leukemia help you to tailor the therapy appropriately. But if I do not have the cytogenetics or if I do not have the next generation sequencing, I should not be training people who are handicapped to deliver therapy in that situation. We need to develop the right people who can develop train them right. And I mean train them right, train them to handle in their context. So just for example, I was in Ghana, in your own country, a few months ago, and there was a child with a white cell count of 300,000 with a mediastinal mass. And there was a research student who had done limited cytometry, and she actually had identified that this is a T cell disease. Now that's enough to treat. I can manage it without knowing the next generation sequencing or the cytogenetics. We got high risk leukemia, which is that is the kind of treatment training we need to do. That if you don't have this, how will you still deliver the care? And if you can't deliver the care, how will you take care of the family? It's not just about the medical component. It's about empathy. It's about palliative care. It's about symptom management. It's about taking care of the family, supporting the family. All these aspects of training has to be done. How will you build a pediatric oncology unit for the future? How will you gradually raise funds? How will you work with governments? How will you collaborate? There are so many facets to being a pediatric oncologist. And that's why I think investing on the youngsters to actually give time for them, you're actually building a future for pediatric cancer. And that's why the interest is so much for me to actually work on youngsters, to make them for leaders for tomorrow and handle new situations and challenges and address those challenges so that ultimately the children benefit. So that's a long, windy answer to your question. Why I wanted to do.
Thank you very much. I was a beneficiary of your training, and I know how passionate you were about it. And from what you've said, I remember when I came to Tata Memorial Hospital, you asked what my setting looked like, and what we are able to do, what we are not able to do. And you continue to remind us along the way that Tata Memorial Hospital is not the typical Indian hospital. You may be blessed with a lot of resources there, but you are also training a lot more people who will not have access to that kind of those kind of resources. And so you were very, conscious of the fact that we may go back and not have those resources. Now, you hinted that you were in Ghana, and let me just, my next question actually borders on that. So again, I was privileged to sit in a session where young pediatric oncology fellows were presenting summaries of their dissertation to a group of consultants for critique. And usually, and not just in Ghana, I have, encountered this in other places where fellows are made to practically defend their work. And usually it carries some acrimonious undertones where the questions and comments could be very harsh. But you did something very different that day. You were very patiently listening to the fellows, and you sought to understand their approach and offered gentle suggestions and comments. Now, this is not usually the standard that we are used to. Considering the large number of trainees you have under you and choosing this kind of gentle approach, why is this important as far as the research career of fellows or trainees in pediatric oncology is concerned, your approach to how you discuss their research work with them? Why is that important to you?
Yeah, so in research, I mean, as the name says, it is researching about something, a phenomena which exists, and trying to find out the reasons for it, or trying to find out the causes for it, and trying to develop interventions which may help you to improve outcomes. Now, we have to allow free thinking here. We have to allow people to imagine. We have to allow people to come up with any thought process which is there. But all those thought processes, all that free thinking has to be discussed and fine-tuned. And some of it may be a fresher who may come up with a great idea, but may not know how to implement it. And that's where senior people will have to step in and say, yes, it's a great idea. Let's fine tune it and make it more doable. So no question from any level of seniority or juniority is unimportant. So I think that's why it is critical to let juniors to open up and talk, because a lot of the ideas which have come for research, even in my experience, has actually come on bedside clinics and rounds. Many times the questions asked by as a junior resident who is doing a pediatric trainee, asking why does this require to be done and why do you think this is, and you might think that this is actually a stupid question, but actually it gets you thinking. So for that reason, I think it is very critical for all the juniors and all the trainees to actually nurture them, take them to the path that research is a infinite field, and there are multiple thought processes which are there, and we just need to brainstorm, discuss with colleagues, allow them to open up, allow them to think, and give them the freedom to not be scared to discuss it out. And I think that is where I feel it's very critical for seniors to actually let the juniors or the trainees to open up and not just negate their idea or push it under the carpet telling that this is not the way to do it. So I saw there was a radically different approach in Ghana when I was there to some of the statistical modeling as well. Now that was itself news to me. Yes, there is more than one way to do a statistical model. It's not this is the only way to do it. So I think we should encourage that. We should encourage that. See, even the research methodology, what we were trained as trainees has undergone a change. Undergone a change to suit with the context of the present day, undergone a change to suit with the present generation, taken into account what is feasible today and what is not feasible today, taken into account what does the patients want. So all those things have fine-tuned and changed the research methodology how we do today. So that's why I think we cannot be with a fixed idea. It's important for the guides or the mentors to actually also be open to new suggestions, and that can only happen if you are actually giving the freedom to the trainees or the mentees to how to actually do it. So that's why I think it's very critical for us not to be too uh, fixated on ideas and impose our ideas onto them, because that's what actually makes them grow. You let them bring out their ideas, you support their ideas, you brainstorm, discuss with them, and it is okay to get it wrong, and it's good to get it right as well.
Thank you very much for that. And again, I was also a beneficiary of that kind of research environment when I was back in Tata Memorial Hospital. Within a year of being there, I did so much. In fact, I was able to publish a paper, even right after, being there for just 1 year, which is a lot. And so we would like to grow in that kind of environment. So again, so my next question, forgive me, this is about young people, so we'll just continue along those paths. So it's a lot of young people in pediatric oncology lack information about where the world is headed in this field. A few privileged ones in low and middle income countries, especially Africa, get information about what lies ahead in terms of, GICC. What the strategy of their country is, what role they have to play to improve childhood cancer outcomes. After all, those high-level meetings that occur at the levels of WHO and etc., that seniors would have attended. What do you think should be done when representatives of countries, okay, who attend meetings at the level of, WHO, GICC, when they return home, what do you think they should do to be able to engage young people adequately on where the world is moving? Because sometimes it feels that, it's the seniors who are discussing the issues around pediatric oncology in the world. And I see a lot of young people not being, pulled along. And in the end, it's their work. It's a lot of their work that would eventually help us meet the targets. So how do you propose the seniors should engage young people after all these high-level meetings?
So that's a very important question, Nihad, and I must say we have thought about it multiple times and discussed it multiple times to how to get the whole department or whole the community involved in global initiatives like childhood cancer, like the GICC of the WHO. So the first thing is that I will tell you our journey, how we did it. So we actually presented to the whole hospital once the WHO GICC policy was drawn up about 3 or 4 years ago. We actually made a presentation to the whole hospital because we wanted the hospital administration, the hospital, all the departments from pathology, everybody, radiology, everybody to know what this WHO GICC is, because in the next few years we knew that will become a buzzword in pediatric oncology circles. So that was the first thing we did. The next thing was when WHO GICC brought out various initiatives to be done. We actually volunteered to be part of some of the initiatives with the WHO, which included maybe part of pathology training, part of this, the nurse training and other activities, which was all geared up to improve childhood cancer outcomes in the region. At that point, it is critical for us to engage many, many youngsters in this and give them roles and responsibility in the WHO GICC activities. So, for example, the tumor board which is run is given to two consultants who are never attended the main WHO GICC meeting. The pathology training is given to somebody else. The nursing training is given to somebody else. And there is radiologists who come onto that. There are surgeons who come onto that. So we got everybody engaged because first we presented what WHO GICC was, both in the hospital itself. Then when the initiatives came, we actually volunteered for many of the initiatives and distributed the responsibility to all of them. But what you're telling is absolutely right, that we need just one person in the department knowing the WHO GICC does not help. For all the WHO GICC meetings which have been held online, including some of the meetings which are held regionally, we have sent different people from the department to attend it so that everybody feels part of it, everybody takes responsibility and onus on it, and everybody actually buys into the idea. See, the WHO GICC will work only if the whole community is part of it. And there are meetings where I have not attended at all, and I've let the juniors, including the fresh trainees, attend the WHO GICC meeting so that they actually understand it and buy it, because everybody has to do it. It is a whole community which has to work on the WHO GICC. And things like registry, data collection, which is all part of some of the initiatives, we have given it to many of the new people to actually take it on. And they have undergone the training from WHO GICC for the registry and data collection, etc. So that I think is very critical. There is no point attending a meeting and not identifying what we need to do. The steps I would say is once we attend the meeting synopsis should be presented in the department, not just to doctors. It should also include nurses and all paramedical people. The next step is to identify what are the activities we can participate in, which is what we did. What are the activities we can participate in? And even one of our directors, who is not a pediatric oncologist, sat in the meeting to see what are the activities we can participate in, because we need buy-in from the admin to participate in those activities. Then we identified 4 activities on which we participated, and the roles of those activities were distributed. Meetings were held with the WHO, and then it was taken forward. So I think that is the 3 steps I would say. First is whoever goes for the meeting comes and presents the synopsis of the meeting, and WHO shares those slides for us to do it in the department meeting. So we use the slides from the WHO. The next thing is to identify the areas which our hospital can participate in, and what are the initiatives we can take from our hospital, and then distribute the work among the people. And then they make them attend the meetings, the online meetings, everything, and they take ownership responsibility. So that's the way we have done. Of course, there are initiatives from the WHO itself. They tell us that this is what has to be done across the country, and that anyway we participate in those aspects.
Okay. All right. Makes sense. Thank you very much for that. And so this brings me to my next question. I think this just pieces things together too. So in Africa, we have a peculiar situation where young pediatric oncologists are technically not young people. Mostly they would have advanced in age because access to training came much later in life. And some of them within the health sector are actually heads of hospitals or heads of departments before they had access to some form of training in pediatric oncology. This is a real challenge for such a crop to access help in terms of growth as far as pediatric oncology is concerned, and also to enter research. They are already seen as people in authority, and they are mostly, but they tend to struggle because it's a whole new field where, in terms of maybe a hospital setups in many African countries, is not the kind of field that brings money into the hospital. And so people may not be very enthusiastic about, growing the service. And so they leave these people struggling in terms of, clinical care. And then the struggle is even worse when it comes to, getting into research. Please, would you like to share some words of wisdom on how people can, in this kind of situation, many of us in this kind of situation, can maneuver the field of the clinical, growth, and also grow their research as well? Like, where do people begin from when they find themselves in situations like this?
So if I understood you right, Nihad, you're telling that many people are senior when they enter pediatric oncology, and there are not many
Yes.
taking up pediatric oncology. So when they actually take, senior people do take up, it is difficult for them to actually enter into research and clinical and all those aspects.
Yes, absolutely. Yes.
So there is, yeah, there is no question. That was the situation in many parts of the world and still is in many parts of the world. And including in India, it went through the same phase that in many parts of the country in India, there was only very few pediatric oncologists. Many of them were pediatricians who also did HIV, infectious diseases, and also received some training in pediatric oncology and started to see pediatric oncology cases. That's how many of the senior people actually delivered pediatric oncology care. And research itself, though research and clinical service go hand in hand, was not really something which they systematically focused on. They focused mainly on delivery of clinical care. And a lot of it was based on limited training which they had received. And so they did struggle with some of the older protocols and they had not been updated. And at the same time, it did not materialize into any significant research because of the lack of manpower, infrastructure, all which are there. So one thing what really helped in many hospitals in the country is actually to start a fellowship program. So starting a training program in pediatric oncology opened up multiple aspects. One is that you are training youngsters who are coming into the field or people younger than you. Two, as part of the training curriculum, you yourself had to be more updated with the most recent knowledge and developments. Three, as part of the curriculum, you also had to teach them some amount of research, which not only helped the trainee, but also the trainer to actually build some research profile. And a lot of the projects or clinical problems which had not been addressed when they were alone were being addressed by them. And that over a period of time gradually uplifted the amount of research being done and the type of quality of care being taken and more systematic way to approach it. So that was one thing which I noticed many senior people did, though they themselves were not able to do a lot in terms of research or clinical care. If I look at all the very senior pediatric oncologists in the country, if you objectively look at their profiles, it looks like, oh, there is very little research done. But they actually have facilitated many, many juniors to actually grow and started training programs, send people to other centers for training for 1 year, 6 months, and build a team and then subsequently build the research. So I think that's what senior people should focus on. It would be very, very difficult to do heavy duty research as a single person if you're in the unit alone. So I would focus first on the clinical component. So it is critical that clinical component is what should receive primary, it should be priority because your research question will only come from from the clinic. And for a research question to come from the clinic, you need to have a systematic, well-oiled clinical protocols or well-oiled clinical system in place. So basic thing what I would suggest for the seniors who are joining in is first sort out the clinical component. Put a protocol which is deliverable to all the children. Make simple data collection on this, on the outcomes. both in terms of toxicity, any interruptions in therapy, any abandonment, any deaths which may be occurring due to any other toxicity, etc., relapse rates, and follow-up. And just putting simple data collection in place without making it very complicated, not very labor intensive, putting routine protocols for delivery of care, treatment protocols in place, which are very deliverable to all the children, and then focusing on aspects how to support the children who are actually coming for treatment. They may need accommodation. It may take few years to build an NGO who may help with accommodation. It may take few years to work out funding to support the children. It may take few years to get drugs supply in place. It may need working with the administration to actually make sure there are no drug stockouts. And so these aspects, how will you work with collaborating with another center for radiotherapy? How will you work for collaborating with another center for surgery in case it's not there? If these aspects we do and we are able to document them, simple things well, that itself is a wealth of data. And that wealth of data actually helps you to identify what is the area you need to focus on. You may find out that 25% of our children are abandoning treatment. So if 25% of children are abandoning treatment, that itself is a big research question. So what can we now do? Can we interview those children who dropped out, or just identify right in the beginning when a new patient comes, maybe 3 monthly follow-up interview, that what are the difficulties you faced while you're taking treatment with us? They may tell you something which is completely not expected, that who will take care of my other child in home? So that's why I dropped out of treatment. I didn't come back for 2 months. Now I come back. Or what's going to happen to my farm for India, for example? That's an important component. I'm the only breadwinner. Who takes care of? Then you start working, okay, these are the interventions I need to work on for the next 5-10 years. Make sure that they don't drop out of treatment. And that identifying such problems and addressing them is what will give the most impact on survival, not high-end genetics or anything in that situation, because there we have to sort out the clinical practice well, and that is what we need to focus on. And that will straight away, if we all the children who walk through any hospital in the world, if are able to deliver care and drugs supply and all, we are sorting it out and support them in a holistic way, we will cure 60% of the children who walk through the hospital. So that's what we should focus on. If you're a single person and you're a senior person and joined in, that's what I would put my effort on, to actually do this component first, identify all the problems which are there in my clinical service and build the clinical service, and research questions will automatically start generating. And the research question doesn't have to be MRD positive or negative. It doesn't have to be medulloblastoma subgroups. Lot of those questions are actually may not be relevant in all parts of the world. And the research question will be, will I be able to deliver 4 weeks of steroid without a fungal infection? Should I actually do 2 weekly to pulse steroids? And those are the questions which we may need to think of. So I think that's how a senior person should do. And by doing that, you start a training program, get juniors who are interested 6 months, 1 year, that helps. The other thing which I think always help is ask the pediatric trainees who are in pediatrics to actually rotate through pediatric oncology. See, it's an unknown field for a pediatric training. And when they actually rotate for 3 months and they get exposure, a lot of them get interested because they actually think pediatric cancer it's a unknown thing, right? So when I trained pediatric training in India, I never thought of doing pediatric oncology because I never worked in pediatric oncology. It's only when I went abroad, and the only place I'd worked was neonatal, specialty was neonatology and pediatric intensive care. So I went abroad to do pediatric intensive care. And then as part of my basic training, when I did there, I realized, oh, pediatric oncology is such an interesting field, and moved on. I said, I don't want to do neonatology or intensive care, and this is my field, which I like. So which is what it is. If you actually focus on these aspects, you can get 60% cure rate with simple interventions and just delivering routine standard of care in the most appropriate way. And I think that should what a person who has joined starting a department or anyone should focus on. And once you get 4 or 5 youngsters, then you can go deeper and deeper into each disease.
Absolutely. Thank you very, very much, Prof. I know that this interview would purpose for many people who are in training and those who have just exited their training. It would really serve great purpose for them in the growth of their field. It's been a real privilege. Now, just before I left India, I started hearing about a cancer grid. And I know that in the field of pediatric oncology, India has really gone far, I mean, compared to other parts of the world. So why is this necessary? And what is the role of young pediatric oncologists in the cancer grid?
Yeah. So the National Cancer Grid is nothing but a network of hospitals, not just hospitals, network of even civil society organizations who are all involved in cancer care for both adult and pediatric. And we created a network for it in 2012. And the idea of creating the network was mainly three things. One is that can we deliver uniform standard of care across the country? Because everybody were delivering variable care and it was difficult for people to know what worked well and what did not work well. So two is that means developing standards, uniform standards across the country. And two, can you actually do research which are very, very contextual to our country? That means answer the research questions exactly as we discussed, like abandonment, access to care, drug availability, quality of drugs, all this. Can we actually do research which are actually contextual to our country and our problems? And third is, can we all share our resources and train manpower adequately in the country so that cancer care delivery can be improved? So can we also, some of them had good radiation training, someone had pathology technician training, some had a good nurse training. Can we all amalgamate all together and make it into one network? So people who want nurse training can go here, people who want pathology training can go here, etc. So that was the whole idea, to develop a workforce to actually make uniform standards of care across the country and evidence-based uniform standards of care, not just take some journal which has been published and implemented. And the third thing, can we ask the research questions which are important for us? And that was the idea of the National Cancer Grid. Now that actually is, at some stage, I feel every country should do that once, or every country or the region has to do that. And that can only come in at we should initiate that at a critical time when the numbers of oncologists are increasing. Now, coming to pediatric oncology, we should initiate at the time, say, at least there are 3 or 4 centers in the country who are delivering pediatric oncology care. So you can start a network that way. By doing that, one, you can all meet periodically and agree on a common protocol across the country so that that becomes easier, and you also have brainstorm with each other on what is deliverable and not deliverable. You share resources. One of you has a surgeon, other doesn't have a surgeon. On the same protocol, the patient can go to the other center and come. All patients can take treatment closer to home. If there are 3 or 4 centers spread across the country, you can go to the center closer to home. Midway, patients want to shift from one center to another center. It is the same protocol. It's easier to shift. So all these can be done. At the same time, you can actually start discussing difficult cases amongst each other. You can actually develop multi-center research among each other. You can actually develop training, both virtual and physical training between all these centers. And by doing that, you actually improve the overall care and also bring a uniform standard of care across the country. The idea was that at some time we should become a force, kind of a soft power in the country, that actually the government also starts noticing and asks us to give our opinion rather than not take opinion from the people on the ground. And that is what has happened in the last 2, 3 years. In pediatric oncology, in adult oncology, we developed the guidelines, and the government actually started asking us that if you are starting government is funding treatment through the national insurance scheme in India, which started a few years back, that for cancer, you have to be on the National Cancer Grid guidelines. Otherwise, you would not get treated. And that not only allowed minimal standards of care to be done for each patient, it also avoided unnecessary treatment for each patient or unnecessary investigation for each patient. So we have put criteria that this is the minimal criteria for actually starting therapy. These are the minimal investigations, and these are minimal infrastructure or whatever is required to start the therapy for this. But all the rest we put as only desirable and not mandatory. So if you didn't have it, you didn't need to do it. So by doing that, the government thought this is more pragmatic, more applicable across the country. And finally, the government did start using us as an advocacy group as well as a think tank to provide them for cancer policy. So, which is what the long-term vision should be, that you develop a network, a collaboration, you do research, you develop guidelines, and then ultimately the government will see the benefit of your network and collaboration and come back to you and say, okay, these are the ones doing pediatric oncology care in Ghana or West Africa. So let's work with them and see what needs to be done for childhood cancer. And you go as a group, then you also have more say in changing government policy, whether it is drug costing, drug importing, new hospital, new positions, training, starting new training programs. In all that, you would have a say. And it's not only doctors who are critical. The point I would like to make is patient advocates are extremely important in this. You must include
Absolutely.
patient advocates in your network because the patient voice, every government gives a lot of attention just than a medical or a scientist voice. The patient voice has a lot of say. So that is extremely critical. Though that's what we have done in the National Cancer Grid. That's what spilled over into pediatric oncology. So we are now having standard pediatric oncology care. We had the first multi-center trial in India, randomized trial in cancer
Okay.
was done in pediatric oncology through the National Cancer Grid. That was the first randomized trial done. Simple questions: 4 week steroid versus 2 week steroids. Is there less mortality and less infection by giving 2 week steroids in India because children come with significant infections, and does it have a good outcome? Uniform data collection, and we understood what are the problems in childhood leukemia. So we're doing now that in Hodgkin's, we are doing that in multiple other tumors, but that's what the outcome was of the National Cancer Grid was.
Absolutely. Thank you very much for that. I think this is a really great learning point for many continents, you know, especially low and middle income countries. For us in Ghana, for us in sub-Saharan Africa, I think that, you know, with even the fact that our number of children with cancers, I mean, on average, those numbers are low. Coordinating together to do things within a short time, you are able to get results that would change your practice. You share the resources that are so limited to look after patients and also to be able to develop training programs and then research. So I think that this is the way to go going forward.
So
And thank you for explaining.
just give another example. In another country where I visited, there were 4 pediatric oncology centers within a 100-kilometer radius. Now,
Okay.
it's not possible for all 4 centers to develop pediatric surgery. It's not possible for all 4. It's not necessary for all of them to do pediatric radiotherapy. So we discussed and we created what is called just a network of pediatric oncology. Not necessarily, it's not a center of excellence. It's a network of excellence, if you can use the term. So between the
That's
4, they
wonderful.
would, and so all 4 of them would have the same protocol. All 4 of them do the same treatment. For surgery, they refer to hospital X. For radiotherapy, goes to hospital Y. Chemotherapy is done by all 4. They have monthly meetings to discuss difficult cases, and so which is what it's done. So I would not wait to build a big network of professionals before you start this process. I would actually start the process as you're growing now.
Okay.
The network as it is there, 2, 3, 4 centers. That's why I said, see, we are 300 centers, but I would say 2, 3, 4 centers I would start, build the network, start collecting data, start talking to each other, discussing, and everybody gives different ideas. You will learn that one has a solution which you had never thought of, and your solution would be helped. So it's a sharing of best practices essentially. And that sharing of best
Absolutely.
practices helps a great deal for patient care and makes
Yeah.
the
Yeah.
of the patient journey much, much better by just sharing best practices. Simple
Yeah.
things that can be done as outpatient therapy. And many people have said, yes, can you do actually ifosfamide outpatient therapy? Yes, many people have done, yes. Do we need to admit? May not be. So many things we can actually share with each other and learn that this can be done. So by doing those things, you're able to actually deliver the care without having to struggle that with the infrastructure issues which may be there.
Yeah. Yeah. Very important point about starting it whilst you are growing and not waiting to do it later. Finally, Prof, what are the lessons you have learned during your entire career as it is now that advanced your career both in the clinical setting and in research? Your personal lessons.
So the first thing I would say is my personal lesson is that patient care is paramount. And I learned maybe a good few years into the job that your research question comes from your clinic. It does not actually come from textbooks. It does not come from journals. It's important to have the knowledge, whatever you can, but your research question actually comes from your clinic. The third thing is do not think that there is only one way to treat childhood cancer, not in terms of the protocol, but in terms of delivery of care. You might have to go innovative, think out of the box to actually deliver the care which is required. If you don't have enough beds and you cannot treat high dose methotrexate, you might have to think of an alternate way to how do I actually do this. Because I still don't have enough beds, I don't have blood levels. Is there an alternate way to actually deliver high dose methotrexate? So that is the third thing I would say, that actually you work to what situation you are in, think out of the box and try to deliver the care and work for your patients. And then by doing that, you'll actually be able to achieve a lot. And remember that whichever part of the world we are in, the suffering of the parents and the child is the same. So we should never ever give up that basic quality as a pediatric oncologist, that whether we are in Africa or Asia or North America or Europe, the suffering the child and the parent goes through, the stress they go to, the anxiety they go through is the same. It is just that in some places they are more communicative, some places they are less communicative. We should not assume that the parents are actually coping well or they are not asking any question. Every parent actually wants their child to live, every parent. And if they are not able to take treatment, we should not reprimand them. There is a reason why they couldn't come for treatment. We must try to deep dive and understand why didn't they come for treatment for this particular child. So there would be a reason for that. Everybody wants their child to do well. So all these things I learned, that never ever assume that the parent doesn't care. Every parent cares. There is the situation may be so difficult for them that the other situation trying to bring may be more difficult than trying to stay back. So all these issues are there. But those are what my life is. I would also say that it's important because it's a long haul, pediatric oncology. It is a stressful field. I will not ever say that it's a chilled out field. And I'm not sure everybody is cut out for pediatric oncology either. So I think pediatric oncology selects you. You cannot select pediatric oncology. For a period of time, it becomes clear whether you really like pediatric oncology or not. And so it's very obvious once you do 6 months, 1 year, whether this field. So I think pediatric oncology selects you. I would still say everybody should have a good work-life balance. In spite of all this which happens, it is important for the long haul, for the sake of the patients, that you actually have a work-life balance. Not having a work-life balance actually on the long run is not good for the patients. So you going home in the evening, having something else to do, you having some other distraction to keep your mind off work, actually makes you come back next day much more fresher and refreshed.
Yeah.
Focus a bit more. Otherwise, it can get so windy that trying to do this, which is an enormous amount of work that needs to be done, you will actually be less efficient 10 years down the line if you don't take care of it. So that I think is very important. You need to have rest. You need to have thinking time and some rest for you to actually think how do I plan for the future. You cannot think if you're always firefighting. So you need to
Yeah.
first work towards that over a period of time, build some systems in place to give you some work-life balance. So it may be difficult in the beginning, but over a period of time, that is critical to develop that and to do that. And that I think will help. But it is a growing phase for pediatric oncology in the world. So from that point of view, it's a very exciting time to be in pediatric oncology for the next 20, 30 years at least. There is a huge focus globally from governmental, non-governmental, civil society, philanthropists, everybody on childhood cancer. The see, every children are important, whether it is malaria, whether it's typhoid, every child is obviously needs therapy and important. But the difference in childhood cancer is that the suffering the child goes through, if untreated or uncared for, I think is enormous.
Yeah.
So for that reason, I think we have to work to alleviate the suffering. That is the bottom line. Whether we cure the child or not cure the child may not be possible in all settings, but we must alleviate the suffering the child goes through. Even a good palliative care. So palliative care doesn't come in the last. Palliative care has to be taught from day one. That's the most critical component, that the suffering of a child is incomparable in cancer compared to other disease. So for that reason, I think it is a very, very critical thing. It's a right of the child that we take care of them, of their suffering, and alleviate their suffering.
Thank you. Thank you so much. I'm sure now Jacques now understands why I chose you. I chose to speak to you. And for me, I thought that, you know, the privilege I had to study under you and many other rock stars in pediatric oncology at Tata Memorial Hospital, others should have that privilege, because that foundation I had was really good, that when I came back and I wanted to start a unit, it was already laid out. The path was laid out. It was, you know, teaching the strong science of oncology and also making me aware of my immediate environment, what will contribute to actually having a successful program running. You know, in my last few weeks there, I was told that you cannot leave without going to sit with Madam Shalini. You have to understand how we get funding to treat our patients. It is absolutely crucial. This is one of the things that can frustrate you if you don't get that knowledge before you leave. So I spent my last 2 weeks sitting in her office, and thankfully, coming home, starting a unit, we've also been able to start a foundation that is supporting the treatment of our children. And so when I had the opportunity, I said, no, I need others to understand and, you know, grow the way I had the opportunity to grow. It may not be one way, but it's important that people also get to hear the story of my life from the source it came from. So thank you so much for sparing time on short notice to do this for us. Thank you so much. This is going to be something that I'm sure Jacques will make available to the whole world to listen. And so people would have the opportunity to grow with such pearls. Thank you so much.
It's a pleasure, Nihad. I must say, when you were here, it was a real pleasure to have you for the whole year. And we were very fortunate that we get to train you, got to train you, and as well as so many people from all over the world who come to train, especially from low and middle income countries. We feel that it is not only fun to be with you people, we also learned a lot training you people, because so many things it's by the exchange of ideas, we have fine-tuned our programs and our approach to childhood cancer as well. I think that interaction is very, very critical between different groups and different settings and different contexts. How do we actually fine-tune childhood cancer treatment? But the last point which you brought out is something which we did not discuss much, but I would like to re-emphasize that involving the society is very, very useful and very critical. You don't have to think that this is the amount of money I need to raise. It can start off with just getting 2 or 3 people to help you as volunteers. And it just spreads, the word of mouth, it spreads, volunteering for this. Then somebody will tell, okay, children's birthday, we start celebrating. So some volunteers will come and start doing children birthdays. Then somebody will tell, okay, I want to donate some money for such and such thing. Then you start a blood donation drive for children with cancer, or even adults and children with cancer, or for your hospital. Then somebody will tell, okay, I will help with nutrition program. And somebody will tell, so it just spreads word of mouth, and it just goes on and on. So from that point of view, every pediatric oncologist, I would say, should work to involve the society. And the society is most of the places, after the initial slow thing, the growth is rapid involvement of the society. Everybody feels for the children. Everybody wants to help out. And it doesn't have to be cancer, with anything else as well. It applies to the same thing, cardiac disease, everything else. But it is something which we should do more and more forthcoming. So that's a very important point which you brought up.
Thank you. Thank you so much. Thank you. We are really blessed to have you. Yeah.
Thank you. It was our pleasure to have you and talk to you today as well. I am myself honored.
So Girish, from my side, I'd also like to thank you very much, because even listening to you, I feel validated as well, because a lot of your thought processes is something that Nihad and I have discussed independently I have never met you in person. So it's really lovely to see that that can be fortified. And I think I will definitely carry that torch. And I think Nihad, as one of my more junior colleagues in Africa, I hope that you will also carry that message, because that is, by continuously saying that, that is where we're going to go forwards. So thank you very much, Girish. And I'm looking forward to talking to you tomorrow, because I've got a lot of questions as well.
Forward to the meeting.
Okay, Nihad, thank you very
you.
much, Nihad, for all those lovely questions.
Thank you for the
Okay, have a lovely
opportunity.
day.
Yeah.
Okay,
Bye.
bye.